Hi, I'm Joanna. I'm a student physical therapist assistant from Carroll Community College.
And I'm Lauren, also a student physical therapist assistant at Carroll Community College.
Today we're going to talk about manual muscle testing of the iliopsoas muscle, one of the hip flexors. The iliopsoas has a couple origins. They start at the lumbar vertebra, the transverse processes, as well as the intervertebral discs and the sides of the lumbar vertebra, as well as the iliacus fossa, or the iliac fossa, excuse me. The two muscles that make up the iliopsoas, the psoas major and the iliacus, both insert into the lesser trochanter of the femur and are innervated by the lumbar plexus. For manual muscle testing of the iliopsoas, you have to know what its action is. So first, with the origin fixed, meaning the more proximal section, the hip joint is going to be flexing the femur on the trunk as in a supine alternating leg raise. When the more distal insertion is fixed, bilaterally it's going to flex the hip joint by flexing the trunk on the femur as in a sit-up from supine position. It also is extremely important for increasing lumbar lordosis bilaterally. Okay, so for manual muscle testing of the iliopsoas, there are a few options, but the standard position is supine. We'll review it first really quick, and then we'll go by it piece by piece. So in supine, the patient is lying on their back. The examiner stabilizes the opposite iliac crest because the quadriceps will stabilize the knee in extension. Then they have the patient bring their knee towards their chest with a slight abduction and lateral rotation, very slight, and then pressure is applied by the clinician over the anterior medial aspect of the leg in the direction of extension and just very slight abduction. Okay, here we see the clinician has had the patient extend her left leg, so we're going to be testing the right. She has her bring her leg up all the way to assess her strength. This tells us that the patient has at least a 3 out of 5 muscle grading, where she can go against gravity in the full range of motion. The clinician has the patient's knee bent so that she can get a true iliopsoas testing. Otherwise, she would get the rectus femoris kicking in. The bent knee puts the rectus femoris on slack. This is just showing the clinician stabilizing the opposite iliac crest. So there's debate among clinicians whether you need to do it or not. If you choose to, you just need to make sure, if you choose not to, you just need to make sure that you're watching for any compensatory movement that will affect the grading by not giving you a true testing. She's trying 2 different ways to see which way is better for her body mechanics and which feels more comfortable to her. And here's just a real quick review for you. Hope it's helpful. The next position is in sitting, and this is just a quick overview if you want to take a minute to pause. Okay, so the clinician is going to have the patient actively raise her right leg and flex as best as she can. Again, this shows that the patient has at least a 3 out of 5 strength grading because she can go against full arc of motion with gravity. She then gives resistance as the patient tries to flex her hip. Here the clinician notices that the patient is bracing herself with her arms against the table, which is a compensatory movement to increase strength. So she just has her, nicely asks her to just gently hold onto the table and not push down with her arms. She redoes the test again, giving resistance to the hip flexion movement, this time watching the patient's whole body, making sure she's not doing any compensatory movement, which she does not. So we get a good test right there. Putting the patient in the sideline helps to eliminate the effects of gravity. However, not all patients will be able to get into sideline, so you just have to make sure that your patient is able to do that first. The patient's going to start laying on their uninvolved side. The involved side will be on top and have better access. They'll then bring their hip up towards their chest against resistance from the clinician. Here we're going to show you just that. This time the patient's laying on her right side, and we're going to test the left, just so that the angle of the camera you can see it better than if she was flipped around the other way. Again, the clinician has the patient go through the motion on her own to make sure she has at least a 3 out of 5 muscle grade strength. This time the clinician adds resistance for testing, and she's also watching the patient to make sure she's not flexing her trunk or doing any other sort of compensatory motion. If there's weakness present in the iliopsoas muscle, the patient may appear to be flat-backed, meaning they have no lordotic curve present. On the far left, we have a neutral, normal lordotic curve. The middle is over-exaggerated, and the right is the flat back, where there's no lordotic curve whatsoever because of weakness in the iliopsoas. Pain can also be a symptom of iliopsoas weakness, oftentimes in the contralateral gluteal region, lumbosacral region during sitting and standing. Radiating pain down opposite knee is possible. Pain usually stops proximal to the knee. Also, there's a delay or difficulty in getting into a fully erect posture when there's weakness or pain.